Good evening, everyone, and thank you very much for joining us for Emirates Society of Internal Medicine Nephrology Wave. Today we have two speakers. First is Dr. Harmuz Dastoor, a consultant nephrologist in Sahha Kidney Center, and our second speaker is Dr. Wasim Ahmed, also consultant nephrologist and associate professor at Khalifa University. Dr. Dastoor will do the first talk. He will give us a lecture about hyponatremia for the internists. It will be about 30 minutes, and then Dr. Wasim will talk about screening and management of chronic kidney disease. Please, if you have a question, send us your question, and after the two lectures, we will have time to answer all the questions. Dr. Dastoor, you may start.
Thank you. Let me just share my screen. Okay. Good evening, everybody, and thank you for joining this lecture on Sunday at 8 p.m. I hope you can hear me. Today, I want to talk mainly about salt and water disorders. And I don't want to dwell too deeply into hypo or hyponatremias. What I would prefer is you just understand the basics of salt and water problems. At the end of the lecture, I'll give you my email in case you guys didn't understand anything. That you can obviously email me, and I can also send you the slides. So the first thing I want to talk about is I found this slide, and it says that to break the rules, you must master them. So for salt and water disorders, it is the same thing. You cannot really understand salt and water disorders until you know the basics, okay? And the basics are not what is given in UpToDate. You know, what you see in UpToDate is this big algorithm. I would try and suggest that you avoid trying to focus on this algorithm. The first step in salt and water disorders is trying to understand that it is a water problem and it's not a salt problem. Especially when it comes to hyponatremia, you must understand that most of the hyponatremias, I would say in 99% of the cases, there is excess of water relative to the same amount of salt. So you have a quantity of salt and water, and that's in a ratio in your body. But if the amount of water goes up relative to the same amount of salt, then your sodium level will go down. So let me start by explaining. When we say a normal sodium level, of 140 millimoles per liter, what we mean is that there is 140 millimoles of sodium in 1 liter of water. So that will give you a concentration of 140 millimoles per sodium. Now, in so-called hypotonic hyponatremias, most commonly like what we refer to as SIADH, what happens is that you have the same amount of sodium. You have 140 millimoles, but the amount of water has increased. So instead of 1 liter, you have 1.1 liter. So when you divide 140 divided by 1.1, you get a plasma sodium of 128. So that is typically what you see in most hyponatremias like SIADH. The total sodium is still the same, but the amount of water has increased. Now in hypervolemic hyponatremias, like you see in CHF nephrotic syndrome, it's a little more different. Here, instead of 140 millimoles, these patients are salt and water overloaded. So there is an increase in salt and there is an increase in water. But the ratio of the increase is different. Here you can see that sodium has increased from 140 to 154. That's only a 10% increase. but the water has increased from 1 liter to 1.2 liters. So that is a 20% increase. So in the ratios, both of them have increased, but the proportion increase in water is greater than that of sodium. And that's why your total sodium, which is your sodium divided by water, goes down, okay? So it's important to note that your plasma sodium is a ratio of salt to water. Either the salt remains the same or the salt can increase, but the increase in water is higher than the increase in salt. And that is why your plasma sodium goes down. So if you understand this concept, it's very easy to treat hyponatremia. Now, my next question is, let's say somebody asks you, hey, what is the total amount of sodium in your body? Can you answer them? After all, you're a physician, right? So there is actually a formula. The total body sodium, that is the total sodium in your whole body, is your plasma sodium multiplied by your total body water. And your total body water is 0.6 times your weight. So if you have a person who is 60 kilograms, his total body sodium, assuming that his plasma sodium is 140, then his total body water is 0.6 times 60, that is 36 liters, then his total body sodium is 5040 millimoles, okay? So by knowing the plasma sodium and the weight of the person, you can actually estimate not only the total body water, but also the total body sodium. And conversely, if you know the total body sodium and the total body water, you can actually estimate somebody's plasma sodium, right? Plasma sodium will be total body sodium divided by total body water. And I'll show you why this is important, okay? Now, the next question in salt and water disorders is, what is the role of urinary sodium, right? So most of us, I assume, are working in a SEHA facility, and there is an order in Salamtech which says urinary sodium. So what is the purpose of this, this order? Well, number one, urine sodium usually helps us estimate the volume status. So if the urine sodium is less than 10, we say this person is volume depleted. Or if the FeNA is less than 1, we say it's volume depleted. Sometimes the FeNA is very low, like 0.1, and that happens in hepatorenal syndrome. Now, besides this, urinary sodium can also help us to estimate the dietary compliance. And I will show you a case number 1, how by measuring the urine sodium, you can actually tell if your patient is following your 2 grams sodium diet, okay? Now, before that, I want you to understand this concept, the concept of molecular weight of sodium and chloride. The molecular weight of one molecule of sodium is 23 millimoles, and the molecular weight of chloride is 35 millimoles. Now, when you tell somebody, sir, you have to be on a 1 gram sodium diet, what you are telling them that 1 gram, which is the same as 1000 milligrams, divided by the molecular weight of sodium, 23, which gives you 43 millimoles. So I think you must maybe try and memorize this, yeah? 1 gram of sodium is the same as 43 millimoles of sodium. This is different from 1 gram sodium chloride. So you may ask me, what is the difference between 1 gram sodium and 1 gram sodium chloride? Sodium chloride is actually table salt. So the salt you eat is not sodium, it is actually sodium chloride. And the amount of sodium in 1 gram of sodium chloride is 1000 milligrams divided by the molecular weight of sodium plus the molecular weight of chloride So that will be 1000 divided by 57, which is 17 millimoles of sodium. So there is a big difference. 1 gram of sodium is equal to 43 millimoles of sodium, and 1 gram of sodium chloride has 17 millimoles of sodium. Okay. Now let's use this information for case number 1. And this is a real case. So I had a lady who came from Sudan, and she had a history of idiopathic peripheral edema. Now I say idiopathic because she had this unusual peripheral edema, and she was worked up for heart failure. She was worked up for nephrotic syndrome and liver failure and thyroid problems. So everything was normal. So somebody said, oh, let's just send him to the nephrologist and let's get rid of the headache. You know? So she came to me with swelling in her leg. So I advised the patient to follow a 2 grams sodium diet. I told her not to take any medication. So she came back with the same edema, and she said she was compliant to her diet. So my question to you is, I did only one test to check her compliance to her diet, and the urine sodium was 224 millimoles per liter. So my question to the audience is, can you estimate her dietary sodium intake under normal volume conditions? That means she has no sodium retaining conditions like, let's say, CHF or nephrotic syndrome. But what we know is her urine sodium is 224 millimoles per liter. And the normal assumption is if you don't have an underlying pathological disease, the amount of sodium you excrete per day is equal to the amount you take in your diet. So let's try and figure out how much sodium she is excreting in her urine in 24 hours, okay? So we know that her urine sodium is 224 millimoles per liter of urine. Now we can estimate that a normal person makes between 1.5 and 2 liters per day. So the total sodium excretion per day will be 224 millimoles per liter multiplied by urine volume, which is 1.5 liter. So the total amount of sodium that she is excreting per day comes to 336 millimoles per day. Now we have to convert that into grams to get an understanding of how much sodium she is eating per day, right? And we know from before, 2 slides ago, I showed you that 1 gram of sodium is equal to 43 millimoles, and 1 gram of sodium in sodium chloride is 17 millimoles. So if she is excreting 336 millimoles per day, if you want to convert it into grams, you divide it by 43 and you get 8 grams of sodium per day. And if you want to convert it into salt, that is sodium chloride, you take 336 divided by 17. So that gives you 20 grams of sodium chloride per day. So you remember I had prescribed for that patient 2 grams sodium diet. She said she was compliant, and we calculated her urine sodium excretion per day. It was 4 times the abnormal of the prescribed sodium. So that showed us that this patient was non-compliant. And then the lady actually told me, yes, she is a Sudanese lady. And apparently, they prepare some kind of meat dish where they put a lot of salt and spices on top, and that may account. Nevertheless, under normal conditions, whatever sodium you take, you should be able to excrete. But I think this woman had some women have some estrogen or progesterone induced sodium retention, and that may be responsible for so-called idiopathic peripheral edema. So basically the treatment we gave this patient was low salt diet and a short course of diuretics to get rid of the extra salt and water. So this is not a case of hyponatremia, but it just highlights how from your urinary sodium, you can actually estimate how much sodium a person is eating. And that can help internists, cardiologists, and nephrologists to assess compliance in dietary sodium intake. Okay, my next question to the audience is urine volume. What is the normal urine volume? And guess what? There is actually a formula for urine volume. It's not a number somebody has just made up. It's not like somebody sat in a room and said, okay, I made 2 liters, so the normal urine volume is 2 liters. No, the amount of urine is actually the osmoles in your urine that you excrete per day divided by your urine osmolarity. So what is osmoles in the urine? The osmoles in the urine are the sum of the substances which have weight. Your urine is made up of water, and it is made up of lot of electrolytes, the majority of which are sodium, chloride, potassium, and the breakdown of proteins, which is urea. And the number of osmoles divided by the urine osmolarity. Now, the urine osmolarity can vary. If you drink a lot of water, your urine will be dilute and it will go down to 50. If I put you in the desert, give you no water, then your urine osmolarity will be 1200. Whereas the normal urine osmolarity is somewhere in the range of 300 to 450. So the normal urine volume would be the osmoles in the urine. On a normal diet, you would excrete about 600 milliosmoles. If you eat a high protein diet, you may excrete 900 milliosmoles, okay? So normally you will excrete 600 milliosmoles, and the normal urine osmolarity is 300. So the normal urine volume is around 2 liters, okay? Remember, the normal urine osmolarity is somewhere around 300 to 450. So actually you can say 600 divided by 300 to 450, which is 1.5 to 2 liters, okay? Now, what is the the minimum urine excretion per day? The minimum urine excretion, which means that if you eat food and you do not drink any water, you will still excrete some urine, because these osmoles are osmotic. So even if you don't drink any water, 0 water, these osmotic osmoles will pull some water out into your urine when they are excreted, okay? So if you excrete 600 osmoles per day and you are not drinking any water, so your urine is highly concentrated, you will still make 0.5 liter of urine per day. So that's where the definition of oliguria comes, yeah? Oliguria is less than 0.5 liter, because the general assumption is if you eat but you don't drink, you will still excrete 0.5 liter of urine per day. Anything less than that is called oliguria. And what is the maximum amount of urine you can excrete per day? So if you are on 600 osmol diet and you drink a lot of water and your urine osmolarity goes down to 50, you can still excrete 12 liters of water. So what happens if you drink more than 12 liters of water? If you drink more than 12 liters of water, then only the water will be retained, and only then you will get hyponatremia. So in a normal person with a normal diet and normal urine diluting and concentrating ability, you have to drink at least 12 liters of water per day before you get hyponatremia. So the question now you will ask me, but why do I see so many patients with hyponatremia in the hospital and they are not drinking 12 liters of water? Because in these pathologic conditions, something else happens. Let's say you have an old woman, right? Our typical hyponatremic patient is an old man or an old woman who is sick, who is not eating well. So the osmoles in his diet, which are excreted in the urine, is not 600, but it is 300. Old people have an ability not to reduce or increase the urine osmolarity. They have a condition called isostenuria, or they may have problems in diluting the urine. So the urine osmolarity stays at around 300. So the amount of urine that they can excrete per day is only 1 liter, right? So if they drink more than 1 liter, these kind of patients will suddenly become hyponatremic. And that's what happens, right? You see these old people, they land up in hospitals, they're surrounded by their loving families. The woman has no appetite, so they give her water and they give her soup and whatever else they give, Pepsi Cola or whatever. And within 12 hours, they've drunk more than 1 liter, and next day you'll find them severely hyponatremic. Okay. So basically, the take-home message from here is that urine volume is a function of your diet and water intake. So simply, if you want to get rid of extra water, in other words, you want to increase your urine volume, there are two ways to do it. Either you increase the osmoles in your diet or you decrease your urine osmolarity. So either one of these, increasing the protein in your diet or decreasing urine osmolarity with the use of drugs like furosemide, will increase your urine volume. You will get rid of free water and then your sodium will go up. If you do both, that is increase the osmoles in the urine and decrease the osmolarity, the sodium will go up much faster. Now, let me talk a bit about hyponatremia. Hyponatremia is the most common electrolyte disorder. It is seen in about 30% of admissions. Hyponatremia, however, is a normal finding in pregnancy. Okay, when you see a normal sodium in a pregnant woman, that is abnormal. It is in fact a sign of volume depletion and maybe a sign of preeclampsia. Hyponatremia is classified based upon the levels of sodium or the symptomology. So it's classified into mild, moderate, or severe hyponatremia based upon the symptoms: headache, nausea, vomiting, muscle cramps, etc., or seizures. Okay. Hyponatremia can also be classified as acute hyponatremia or chronic. Acute if it's occurring less than 48 hours, or chronic if it happens in over more than 48 hours. The symptoms are more or less the same. Why is it important to know about hyponatremia? Because hyponatremia, especially the rapid correction of hyponatremia, leads to complications and a lot of medical malpractice payments, right? Here you can see. Hyponatremia can also be very subtle, right? So in older people, hyponatremia can be presenting as headache, nausea, vomiting, and irregularities in gait. If you see your old grandma having irregularity in gait, then you may think about hyponatremia. And I think this person also has hyponatremia. Let me see if I can get this video. Do you know this person? Yeah. I think I may have just diagnosed him having hyponatremia. Here he is again. Yeah.
I wish they accept teleconsult for you.
Oh.
You can charge them.
Thank you. Guys, if you give me 10 minutes extra, I know if I can carry on till 8:40, because even for me, this lecture is interesting. Now, we know that acute hyponatremia can cause swelling in the brain cells. So that condition is called hyponatremic encephalopathy. Whereas the treatment, the rapid correction of hyponatremia, is even more dangerous, right? We know that that can cause what is called osmotic demyelination syndrome or central pontine myelinolysis. Okay, that where there is swelling in the brain cells. Sorry, this is hyponatremia, right? The brain cells swell, and the brain is in an enclosed cavity. So the only place where it can go is push down into your spinal column and cause herniation. Now, this slide is very important. So try and figure out this slide. Here we have a normal cell. You drink a lot of water and you get acute hyponatremia. Acute hyponatremia is When your plasma sodium goes down to 120 and the brain cell is still 140, what happens is there is an influx of water which dilutes the sodium in the brain cells. So the sodium in your brain cells also becomes 120, but it comes at the expense of swelling of your brain cells. Over the next 2 to 3 days, these osmotic molecules like organic solutes, potassium, and phosphates, they leave the brain cells. So the brain cell becomes somewhat smaller, okay? So in acute hyponatremia, you have an enlarged brain cells, and chronic hyponatremia, the brain cell is enlarged relative to the normal cell, but it's smaller than in acute hyponatremia. So when you have an acute hyponatremia with acute swelling, before the changes can happen, if you rapidly reverse this, it is less harmful. So if you see some of the recommendations of acute hyponatremia, where you had a marathon runner and he comes in with seizures and acute hyponatremia, you are safe in correcting this hyponatremia very quickly by giving them 3 boluses of 100 ml, 3% normal saline, okay? So you wouldn't be faulted for that. When you have chronic hyponatremia, and if you rapidly correct it, what's going to happen is the cell, which is already shrunk over here, is going to shrink even more. Okay, so it'll shrink even more than the normal cell, and this is where you get central pontine myelinolysis, and this is a true case. So when I was at Rahwa Hospital, unfortunately, the sodium was corrected very quickly from 100 to 115, and the patient presented with central pontine myelinolysis, not immediately, but for around 2 to 4 weeks later, and we still have issues with the case. Now, if anything, if I want to teach you anything on hyponatremia, even before going on to the case of SIADH, I want you to understand this concept, right? If I was to drink 1 liter of water, that means my plasma sodium went down to from 140 to 135. What would happen, right? In a normal person, the ADH would be suppressed, and then you would excrete dilute urine. And as a result, my sodium would go back from 135 to 140. But because I am excreting dilute urine, the markers of ADH suppression are a urine osmolarity, which is less than 100, or a specific gravity that is less than 1.003, which means that if you see a normal person who has hyponatremia, the normal urine osmolarity that you will expect should be less than 100 milliosmoles per liter. That is, if you and me drink water today of around 1 or 2 liters, I will expect that my urine osmolarity is less than 100. If you go and see a patient of hyponatremia and the urine osmolarity is more than 100, there is a problem. This is a pathophysiologic response, and that may explain their hyponatremia. Okay. So this is once. Let me just go through it. Let me just bypass this slide. You should know that if you see a patient with hyponatremia and the urine osmolarity is more than 100, there should be 2 things going on in your mind. What are the stimulators for ADH excretion, which is making this patient's urine osmolarity more than 100? And there are only 2 stimulators for ADH excretion, which will make your urine osmolarity more than 100. The first is volume depletion. Volume depletion is the strongest stimulus for ADH. If you are shot, if somebody shoots you and you are bleeding, okay, you will lose volume, renin, angiotensin, aldosterone, and ADH is going to be excreted, okay? The other stimuli for ADH excretion are abnormal conditions. We call them SIAD, or I would prefer to use the term called ADH-like disorders, which include nausea, vomiting, pain, hypothyroidism, CHF, nephrotic syndrome, etc. So let me just go over this classification. If you see a true hypotonic hyponatremia, right, the normal response should be a urine osmolarity less than 100. But if you see a urine osmolarity more than 100, the first question you must ask yourself is, why is this person's urine osmolarity more than 100? Because in my lecture in the Emirates Society of Internal Medicine, the nephrologist told me that the normal response is less than 100, but this patient's response is more than 100. So what are the two causes of a urine osmolarity more than 100 in a patient with hyponatremia? Number one is volume depletion. You examine the patient, is he volume depleted? Yes, if he is volume depleted, then it is hypovolemic hyponatremia. But if the patient is euvolemic or hypovolemic, then they may have SIADH or ADH-like disorders, which are causing excessive ADH excretion. We know that in CHF, there is low kidney perfusion. The kidney perceives a low volume status, so ADH is excreted. Nausea and pain are causing ADH excretion. Okay, so finally, if you give me 2 minutes more, I just want to present a case to you. Also a good case I saw. It's good for internists, yeah? So we have a 54-year-old Saudi gentleman who presented to emergency room with headache and lethargy. His plasma sodium was 113, that is hyponatremia. His plasma osmolarity was 232. So it is a true hypotonic hyponatremia. What did I tell you? If you have a patient with hyponatremia, look at the urine osmolarity. If this person is normal and does not have any ADH, SIADH or ADH-like disorders, then his urine osmolarity should be less than 100. His urine osmolarity is more than 100. So I know that I have to ask two questions. Number one, is he having volume depletion, which is causing ADH release and increasing his urine osmolarity? Guess what? No, because on my physical examination, he is euvolemic. So the second question is, does he have SIADH or ADH-like disorders, right? The ADH-like disorders could be thyroid problems, CHF, etc. And he's not hypervolemic, he is euvolemic. So my assumption is he has SIADH or maybe nausea, vomiting, pain, or medications which may cause ADH release. And actually, yes, he was on bupropion to stop smoking, which can cause the patient to have SIADH-like disorder. So this patient was found to have symptomatic hypotonic hyponatremia, and the treatment was to give him hypertonic saline. And we gave him 3% saline and we stopped the offending agent. So if you want to know how much 3% saline to give him, first of all, you have to understand what is 3% saline. 3% saline is 1 liter of 3% saline is basically 1 liter of pure water with 512 of sodium, 512 of chloride, will give you an osmolarity of 1024. In other words, every 2 ml of this solution has 1 millimole of sodium, okay? So you have to know this. 1 liter of 3% sodium chloride is 512 of sodium in 1000 ml of water, or mathematically you can say every 2 ml of this solution has 1 millimole of sodium. Now your target sodium is 120. So your sodium deficit, you want to correct this patient's sodium from 113 to 120 over 24 hours. So the sodium deficit will be 0.6 times body weight multiplied by your target sodium minus current sodium. So the sodium deficit is 294 millimoles. You have to give this patient 294 millimoles over 24 hours to raise his sodium from 113 to 120. or you have to give him 12 millimoles per hour, okay? So because remember, you are correcting it per hour for the next 24 hours. So you give him 12 millimoles of sodium per hour. And if you are giving him 3% sodium chloride, we know that 1 millimole of sodium is 2 milliliter of this fluid. So if you have to give 12 millimoles per hour, you have to give 24 milliliters per hour of 3% sodium chloride. And using this formula, you can correct hyponatremia. Long-term management, remember, if a person has SIADH long-term and it's not reversible, all you have to do is increase the urine volume and free water. So the only way to do it, as I showed you before, is you increase the osmoles in your diet or you decrease the urine osmolarity. You can increase the osmoles in your diet by giving a high protein diet or urea, which is not available here, or you can decrease the urine osmolarity by giving them drugs like lithium, minocycline, furosemide. I don't use lithium, I use minocycline and I use furosemide. If furosemide doesn't work, I usually give them minocycline. How do you give them protein? There is a complex formula I created, but basically if you give these patients 3 Al-Islamia jumbo sausages, here is the formula. I don't have time to present it. If you want to know the numbers, please email me and I will share this presentation with you. Remember, you have to give the jumbo beef sausage. Don't give the chicken sausage, yeah? Big difference. The beef sausage has more protein. I calculated there is 12 grams of protein in 100 grams of sausage. Each sausage is 85 grams. So the numbers are based on this. And then I don't want to do case number 4, which is a case of cerebral salt wasting. But I hope you understood the basics of this lecture. If you have any questions, please email me and I will send you the presentation. If you want any explanations, you can also call me. Thank you.
Thank you very much, Dr. Dastur. Actually, you passed your time by 3 minutes. Just to comment, the beef sausages taste better than the chicken.
I know. I stopped eating chicken sausages. They're horrible.
Well, I still love them, to be honest. I can't quit
But
them.
just to let you know, and just to let the audience know, the beef sausages in IKEA are better than the one in Al-Islamia.
I agree. Yes,
Okay.
I tried them. They are huge as well. So we can move to Dr. Wasim, and then we have time for questions. Dr. Wasim, maybe? Dr. Wasim?
Yes, thank you. I'm just sharing my slide. Bismillah ar-Rahman ar-Rahim. Good evening, everybody. Thank you, Dr. Dastur, for an excellent talk. Hyponatremia is always a difficult topic for everybody, and I think you made it very simple. So what I'm going to talk about is how to screen and what we can do to slow the progression of chronic kidney disease. This is something which we see more and more in internal medicine clinics and cardiology, practically everywhere now, and is increasing. So my talk will be covering the screening and early identification of chronic kidney disease. I'll touch base a little bit on prevalence and clinical significance of chronic kidney disease, and then strategies to slow the progression of kidney disease, which includes diabetes and hypertension, and some emphasis on SGLT2 inhibitors. So when you start screening for a disease, it's very difficult to screen the whole population because it's not going to be cost effective. So you need to identify the high-risk patients or high-risk population. For them, you can screen. So we know that patients who are diabetic are high risk for CKD, hypertension. I would say especially young. We see a lot of patients who tell us that they were diagnosed with hypertension when they were very young, perhaps in 30s or in their late 20s, but never had a kidney function done. And then suddenly they will appear in our clinics with severe advanced kidney disease. Somebody who has systemic disease, for example, SLE, patients who have cardiovascular disease, a previous history of acute kidney injury, a family history of kidney disease, somebody who's had a preeclampsia, high BMI. And nephrotoxins, and this is something which sometimes we overlook. Some patients, because of their arthritis, may be on long-term non-steroidals. Some patients may be on lithium, which is also nephrotoxic, and patients who have kidney stones. So how do we, what are the tests we do to identify CKD? We are all aware of serum creatinine. I think the identification of kidney disease is probably very cheap, relatively. So serum creatinine is one of the serum tests which we do. And now I believe most of the labs in UAE will report an automated eGFR, which is estimated glomerular filtration rate in ml per minute. We also look for urine albumin creatinine ratio. So basically, we're looking at whether the patient has albuminuria, and albumin creatinine ratio is very sensitive at low levels, identifying low levels of albuminuria. And sometimes that's the only early marker of kidney disease. And nowadays, we don't do 24-hour urine protein excretion or 24-hour urine volumes unless the patient is in hospital, because it's even in hospital, it can be very inaccurate. And urine albumin creatinine ratio in a morning sample, just a spot sample, can be very informative. And if either of those are abnormal, you can do urine analysis. And the advantage of urine analysis is that you can identify if the patient has kidney disease, for example, a glomerulonephritis, if there are presence of RBCs in addition to proteinuria. And after all three, we usually go for an ultrasound to look for any structural abnormalities to see whether the patient has two normal-sized kidneys, there's no obstruction, and there's no disparity of the kidney size. So these are simple tests which we can do in patients who are at high risk to see if they're developing kidney disease. Because remember, kidney disease is a silent disease in majority of the patients. The other thing to remember about creatinine, although it's a very common test, we do it perhaps every day on so many patients, but it starts to rise when patients have already lost 50% of the GFR. So if the creatinine is, let's say, 110 or 120, that means the GFR is already significantly reduced. We have to be careful when we estimate the serum creatinine, especially in patients with extremes of muscle mass, in somebody who is, is a bodybuilder, with patients who have muscle wasting disorders, those who have an amputation, and in pregnancy. So in patients who have reduced muscle mass will lead to overestimation, and increased muscle mass will lead to an underestimation of GFR. So albuminuria is classified into a mildly increased albuminuria, which is an albumin excretion of 30 milligram per gram or less than 3 milligram per millimole. A moderately increased albuminuria, which is between 30 to 299 milligram per gram. In Saha, we use mostly milligram per millimole, which is 3 to 29. And then severely increased albuminuria, which is going to be more than 300 milligram per gram or more than 30 milligram per millimole. Now, why do we classify this into three categories? I'll touch base in the coming slides. So what is the definition of CKD? So CKD is defined as structural or functional abnormalities of the kidney, which have to be present for 3 months or more. This guideline suggests that if you have a abnormal renal function were done for the first time, you must repeat it after a few weeks, depending on how bad that is at the presentation, to see if it persists. And if it persists more than 3 months, it is classified as CKD. But what we mean by structural or functional abnormalities, it means if the ultrasound, for example, shows a small kidney, irregular kidneys, patient has proteinuria, or they have renal serum abnormalities suggesting the patients may have tubular syndromes, or if they have a transplant and the GFR is less than 60. Then we divide the kidney disease into 5 stages. The stage 3 is divided into 2 further stages, 3A and B, and this is based on patients' eGFR. The couple of the reasons we divide them into stages is that every stage has its own strategic strategy, how to manage. And also we can, over a period of time, when we follow the patients, if the patients are moving from one stage to another stage, we can see if the patients are either improving or the kidney function is getting worse. I'm sure all of us are aware of the stages of CKD, so I won't get into details, but I just wanted to give you an idea why we use the stages. Now, albuminuria, as I mentioned earlier on, can be used to further classify patients with kidney disease. So in this classification, we have the GFRs on the left, and then we have the severity of proteinuria or albuminuria on the right. So we can then, based on patients' eGFR and protein excretion, we can plot them on this graph and see where do they land. So if they land in a green box, they have a low risk of CKD of progression, whereas if they are in the yellow, they have a moderately increased risk. If they land in a orange, they have a high risk, and if they fall into a red box, they have the highest risk of CKD progression. And I think this is very useful to have this in our clinics when we see the patients, especially for colleagues in internal medicine and in primary care, so that they can see that who is a high-risk patient for progression, and we can target our therapies much more aggressively for these patients. So if somebody has a creatinine of 150, what does that mean? Does it mean anything? And I'll just try to highlight what is the clinical significance of CKD. But first, we need to know what is how big is the problem. Now, in US, more than 1 in 7 people have CKD, and they estimate that they have 15% of US adults have CKD, some form of CKD, and it's about 37 million people, so it's a huge number. And the problem is that because it's silent, 9 in 10 adults with CKD actually do not know that they have CKD. Either they never had it, a test done, or they're not educated, or they did not have symptoms, which it's a silent disease. Unfortunately, it's a very expensive disease to treat. So in US, it's estimated about $114 billion is spent to treat both CKD and end-stage kidney disease. So good reason to work early and reduce the progression. And the worrying thing is that CKD will be the 5th leading cause of death by year 2040. This is the data from UAE a few years ago, which shows that in Abu Dhabi, 1 out of 10 to 12 people may have CKD, and we're just reviewing the current up-to-date prevalence, and it actually may be more common than what it was in 2015. And they also suggested that there could be 12 to 15% rise in end-stage kidney disease population in the next 5 years. So we're going to see a huge end-stage kidney disease population if we are not going to be aggressive in the initial parts of CKD management. Most common causes are diabetes and hypertension. Almost 70% is diabetes and hypertension, and then we have glomerulonephritis, and sometimes patients present with end-stage kidney disease where we do not have a cause. The kidneys have shrunken for a number of reasons. The other thing, as I said, diabetes is almost 40% cause of CKD. UAE has one of the highest rates of diabetes in the world, and as compared to UK, which has 4.9% prevalence, we have reported up to 30% to diabetes, and additionally 12.5% have impaired glucose tolerance test. This is a map from International Diabetes Federation, and it shows that in our region, we're going to see a huge increase in diabetic population, almost about 90% increase in population with diabetes but in the next 20 to 25 years, which is going to be significant, not only for the patients, but also for the healthcare system. The worrying thing is that this is current data that patients who are diabetic, who die before the age of 60 in our region, we have the highest rate. 12% of patients who have diabetes die before the age of 12. So we have the highest rate of deaths in patients who are below the age of 60 with diabetes. So what implications does it have for CKD patients? This is a US data which suggests that the patient who has end-stage kidney disease has the worst prognosis as compared to somebody who has even compared with cancer or heart failure. So although we have done, we're doing a lot better in terms of dialysis and having new techniques of dialysis and adequacy of dialysis and number of other interventions, our dialysis population still has the worst mortality as compared to a lot of other comorbidities. And this also suggests that as the GFR goes down, the cardiovascular event starts to go up, rates of hospitalization go up, and mortality also goes up as the glomerular filtration deteriorates. Cardiac dysfunction is very common in patients who start dialysis, and this study shows that patients, almost 74% of patients have LVH when they start dialysis treatment. And as we know that LVH is an independent risk factor for morbidity. About 35 patients have LV dilatation, and about 15% have LV systolic dysfunction at the time of starting dialysis treatment. And obviously, all these things have developed over a period of time because of perhaps the inadequate interventions at an early stage. We see a lot of patients in our inpatient. Most of our consults are now coming from cardiology, where patients are admitted with heart failure and kidney disease. And I'm sure you guys also see a lot of CKD with heart disease in your clinics. So the prevalence increases, the heart failure prevalence increases with declining kidney function, and it causes more ER visits and hospitalization. 80% of ESRD patients diagnosed with heart failure are expected to die within 3 years from type of diagnosis. So heart failure and kidney disease is not a good combination. So really, we need to identify CKD early. It's a silent disease. It's a costly disease. It has high morbidity and mortality. We need to do interventions early to slow the CKD progression, and then interventions to improve cardiovascular outcomes. So this study shows that if we intervene early, we can improve in 20% of the patients, we can actually improve their kidney function. 60% with either will stabilize or improve. Unfortunately, 20% may still progress to end-stage kidney disease, but it depends at what time they present to us and how aggressive we are in terms of managing their kidney disease early. And not only that, it's cost effective. We can save about almost 250,000 dirhams per patient per year if the patients do not go on dialysis, which is a huge cost to the healthcare system. So let's talk about what do we do to prevent the progression. We need to target the hypertension, manage the diabetes very aggressively, and avoid obviously any other acute kidney injury along the way with nephrotoxic medication or contrast. Contrast is one of the commonest procedures patients undergo, especially in hospital, and they are sick during their time, and that can sometimes lead to worsening of their kidney function. We need to reduce cardiovascular mortality by using statins, aspirin, and as I will talk about, SGLT2 inhibitors are now part of not only diabetes treatment, but also to reduce cardiovascular mortality. And then we have to treat the complications of chronic kidney disease if patients are progressing, which includes anemia, mineral bone disease, acidosis, fluid overload, malnutrition, and then we have to prepare for renal replacement therapy. So for this talk, I will just be concentrating on phase 1, which is the early management. Obviously, patients need to be educated about exercise and healthy eating and smoking cessation. But from physician's point of view, the main intervention will be blood pressure, glycemic, and lipid control. So what do the guidelines suggest about blood pressure? I think the important thing about blood pressure control is that we need to individualize the treatment. Somebody who is an 80-year-old may not be able to tolerate a blood pressure of 120 over 80 systolic. So KDIGO suggests in patients with CKD and hypertension, we need to target a systolic blood pressure of around 120 over systolic. As I said, we need to individualize. If somebody's young, they can tolerate it, but we don't want elderly patients to be falling over. NICE from UK has given a little bit more broader picture, and they base their blood pressure targets based on the albumin excretion rate. So if the albumin excretion rate is less than a gram in 24 hours or 620 milligram per gram, the target is less than 140 over 90, with a target range 120 to 139 systolic. However, if the patients have a higher degree of albuminuria, we know, as I showed you earlier on, that these patients may be in the red box and they are high risk of progression. But these patients, we need to target a blood pressure of less than 130/80 with a systolic target between 120 to 29. Again, based on patient tolerance. These are two studies using angiotensin receptor blockers and chronic kidney disease. They are fairly few years old now. However, this is losartan versus placebo and irbesartan versus amlodipine and placebo. And both studies showed that ARB was significantly better in terms of reduction in albumin excretion rate and doubling of serum creatinine, kidney failure, or death. So the standard of care in patients with CKD, the first-line agent has to be an ACE inhibitor or angiotensin receptor blocker. So this is just an algorithm to our colleagues to how to monitor ACE and ARB. So I suggest checking the serum creatinine and potassium in about 10 days time to see if there's been a rise in creatinine. So if the patients are still normokalemic and the creatinine has risen less than 30% of the baseline, then we can increase the dose of ACE or ARB until the maximum tolerated dose. And I think the important thing here is that we quite often see patients are not getting the maximum dose of RAS blockade. They may be on a small dose and they have additional antihypertensives. So we need to really maximize the use of RAS blockade as long as they don't have hyperkalemia or the creatinine has not gone up more than 30%. If the patients become hyperkalemic, we can consider adding a diuretic. If they have acidosis, we can add sodium bicarbonate. However, previously we were quite restricted if the patients became hyperkalemic, but now we have patiromer and sodium zirconium cyclosilicate as new potassium binders. They are available in the UAE now, or almost going to be available. One of them is already available. So we can use these potassium binders along with the ACE and ARB and they give the patient the maximum benefit of the RAS blockade. However, if the creatinine goes more than 30% from the baseline, we need to look at if the patient has had any other medication which could cause this degree of rise in creatinine, make sure the patient's volume depletion is corrected, and they're not on any non-steroidals. And you can always decrease the dose of ACE or ARB and then recheck the creatinine and potassium in again about a week's time or so. If it continues to go up, then it's safer to stop and then reassess the situation. So the message from this is that we need to maximize the RAS blockade in patients with CKD as long as the creatinine doesn't go up more than 30% of the baseline and the potassium is corrected, is controlled. The next thing is reducing cardiovascular risk. So the guidelines are that all patients with CKD above the age of 50 should have a statin. Either a statin or a combination of statin and ezetimibe. If the patients are between the age of 18 and 50, then we need to assess their cardiovascular risk. If their 10-year cardiovascular risk of having an MI is more than 10%, if they had a coronary artery disease before, or if they have a stroke, then we give them a statin. And aspirin is recommended unless there is a risk of bleeding, which outweighs the benefits. So SGLT2 inhibitors, I will talk about in a minute, is not only part of diabetes control now, but also part of the reduction in cardiovascular risk factors or improving cardiovascular morbidity and mortality. So what do the guidelines suggest about diabetes? Again, individualize the target. If the patients can tolerate, then the A1C target between 6.5 to less than 8. The first line treatment should be SGLT2 inhibitors in type 2 diabetes and CKD. Before the starting GFR was 30 mLs per minute, but the recent studies have shown that they can be started with a GFR of as low as 20 mLs per minute. If the target is not achieved, then you can always add a long-acting GLP-1 receptor agonist. So what exactly happens in diabetic nephropathy? It's important to know before we understand how do the SGLT2 inhibitors work. So patients who are in diabetes, the hyperglycemia leads to increased proximal tubular glucose delivery in the proximal tubule, and this results in a absorption of sodium and glucose with the sodium glucose co-transporter present in the proximal tubule. Now, this results in less sodium delivery in the macula densa, which then promotes the efferent arteriole vasodilatation. So efferent arteriole vasodilatation leads to increased glomerular pressure and hyperfiltration, which then results in diabetic kidney disease and proteinuria. So what SGLT2 inhibitors are doing is they are blocking the sodium and glucose reabsorption at the proximal tubule. And therefore, more sodium is available here at the macula densa, and it just reverses the process. It reverses the vasodilatation, it causes vasoconstriction, and the glomerular pressure goes down, and there's inhibition of hyperfiltration and the related injury. And therefore, then we get natriuresis and glycosuria as a result of SGLT2 inhibition. In addition, SGLT2 inhibitors also have a diuretic effect. They cause reduction in blood pressure, and there's some evidence that they also cause some degree of weight loss. So a couple of major trials. I'm not going to bore you with a lot of data, but most of the, actually almost all trials with SGLT2 inhibitors have shown benefit in terms of cardiorenal protection. So this is a DAPA-CKD study published about 2 years ago. And they used dapagliflozin 10 milligrams along with a standard of care and placebo. And it showed that there was a significant improvement in the outcomes. There was a reduction in composite death of cardiovascular causes or hospitalization. The kidney disease progression was slowed down, and death from any cause was also significantly reduced, and the number needed to treat was only 17. This is a very recent study just published last month, empagliflozin in patients with chronic kidney disease. And again, this study showed that mainly diabetics, but not only but patients without diabetes and without albuminuria, empagliflozin was actually beneficial, and it slowed the progression of kidney disease. So this is what the trial data showed. So empagliflozin was better in terms of progression of kidney disease. It slowed the progression and also improved cardiovascular outcomes. So the summary of SGLT2 inhibitors is diabetic or non-diabetic chronic kidney disease, albuminuria or no albuminuria. They should be one of the top drugs to be used in patients with chronic kidney disease, along with RAS blockade. So this is just a summary of the diabetes and hypertension management. Won't go into details, but SGLT2 inhibitors, if the GFR is more than 20, along with metformin, if the GFR above 30, RAS blockade, statin, and then GLP-1 receptor agonist as a second line, and calcium channel blockers or a diuretic if the blood pressure is not on target. One thing I would just like to mention here, perhaps not too much in detail, is the use of non-steroidal mineralocorticoid receptor agonist like finerenone, which is now being recommended in patients who still have proteinuria despite being on a RAS inhibition and SGLT2 inhibitors. Just to quickly also inform you that SGLT2 inhibitors is now a part of the management of heart failure as per this year's AHA guidelines. I think the SGLT2 inhibitors are now becoming more commonly being used, so we need to just be aware of some of the things when we start these drugs. As with RAS blockade, they can also drop a GFR. As I mentioned, the mechanism of action is reduction in the intraglomerular pressure. So it's mostly a hemodynamic change, and it's reversible. It causes, so the reduction in GFR is because of reduction in intraglomerular pressure. And if the increase in creatinine is up to 30% from the baseline after starting SGLT2 inhibitors, that is acceptable. So there's no need to stop, but I think we should still monitor it to make sure it's not going up. However, if it goes more than 30% from the baseline, we should hold and assess the volume status. This is most studies have shown that there's always a dip in GFR initially when you start SGLT2 inhibitors. However, over a period of time, the GFR stabilizes and is actually better at the end of the study as compared to placebo. When we have SGLT2 inhibitors, we need to be adjusting the dose of some of the other anti-diabetic medication. For example, sulfonylureas and glinides, we either need to stop or reduce the dose by 50%. However, if patients are on metformin, GLP-1 agonists, DPP-4 inhibitors, or glitazones, there's no reduction of dose needed. If the patients are taking insulin, if they are only on basal insulin, we need to reduce by 10%. If they are on basal and pre-meal bolus insulin, we need to reduce the bolus insulin by 10 to 20%. And the important thing is that we need to do this in a stepwise fashion because there's a risk of diabetic ketoacidosis in patients taking SGLT2 inhibitors. The common adverse effects, as I mentioned, is they do cause volume depletion, so they can cause dizziness and hypotension by reducing the blood pressure. Diabetic ketoacidosis is one of their other side effects which we need to be aware of. Can cause urinary tract infections, and patients who are prone to urinary tract infections or who've had urinary tract infections, perhaps we need to be careful not to use them in those patients. The lower limb amputation, there's only one study which showed some increase in the risk. However, it's not been shown in other trials. So whenever we start these drugs, assess the volume status and the blood pressure. So if the patient is hypovolemic or hypotensive, reduce diuretics, reduce antihypertensives, and then start SGLT2 when the euvolemia is restored. If the patients are euvolemic and normotensive, diuretics and other blood pressure medicines may need to be reduced because patients may become hypotensive after starting SGLT2 inhibitors. However, if the patients are hypovolemic or hypertensive, there is no need to adjust the other medication. Patients can develop euglycemic diabetic ketoacidosis. This is something which we need to be aware of when we're using SGLT2 inhibitors, and it can be difficult to diagnose. Even with glucose of around 10 to 14, patients can develop DKA. Patients will have symptoms of nausea, vomiting, and abdominal pain, and have high anion gap metabolic acidosis and ketonemia. So this is something we need to be aware of if patients present to us and they are on SGLT2 inhibitors. Also to remember is a sick day protocol and peri-op management. So if the patients are ill for some reason, or they have excessive exercise or alcohol intake, they need to hold SGLT2 inhibitors and until they are eating or drinking and they're back to normal. If they're having a day case procedure, we should stop SGLT2 inhibitors on the day and limit fasting to the minimum. If they're having a inpatient procedure, then we need to stop it for about 2 days in advance and start when the patients are eating and drinking normally. So this is about SGLT2 inhibitors, RAS blockade, lipid, cardiovascular, reduction in cardiovascular morbidity. Other things which we need to do in terms of management is if patient needs to have a contrast and they are known to have CKD, we need to consider giving them normal saline infusions before and during and after the procedure. And during this, we need to also hold the RAS blockade and diuretics if it's possible to assess by volume status of the patient. Prolonged use of non-steroidals should be discouraged if possible. If there's no choice, patients should be monitored very closely. If the patients develop metabolic acidosis along the way, we should give patients oral sodium bicarbonate, and that has also been shown to slow the progression of kidney disease. As the patients progress, we need to vaccinate them for hepatitis B because we know that as patients do not have a good immune response when they develop as the GFR goes down. So sometimes patients do not develop a good immune response. And I think one important thing which our colleagues in medicine should be aware of, that if patients have advanced kidney disease, try not to use their major veins for phlebotomy, use the back of the hand, for example, or non-dominant hand, because these patients might need to have a fistula later on. And if we use their major veins, sometimes thrombosis can jeopardize their fistula formation in the long term, which can be their lifeline. If patients are on non-steroidals, they must be, as I said, monitored. Depending on the cause of the pain, you can try other non-steroid, drugs like Lyrica or gabapentin, but depends what the pain is, what's causing the pain, and it may be worth referring to pain management if it's available. If patients are on lithium or cyclosporin, then they should be monitored as well for a silent kidney disease. Now, there will be some patients who will progress to advanced kidney disease despite our best efforts. And as you're all aware of, these patients develop a lot of metabolic and biochemical abnormalities. They become hypocalcemic, anemia sets in, hyperphosphatemia, hyperkalemia. So all these complications then set in as the kidney disease progresses. And it's not only these which we have to deal with, it's the physical and the psychosocial aspects of kidney disease if we're not aggressive in the initial part. Quite often we see patients who suddenly find out that they have advanced kidney disease, or they have to have dialysis. We've seen so many patients lose their earning. It's totally a life-changing event. They have fluid and dietary restrictions, especially in young people, young patients. You tell them not to, restrict their fluids. It's very difficult to do that. So it's all good reasons that we need to be aggressive in the initial stages of CKD. So the other important thing I wanted to highlight for our colleagues is when to refer to a nephrologist. If the patient says AKI, it's an immediate referral. If patient has nephrotic syndrome or kidney disease as part of the multi-system involvement, then you can refer us urgently. We are always available. You can always call us at the Saha Kidney Care, and we can accommodate the patients very quickly. Routinely, if the patient's GFR is less than 30 or if they have heavy albuminuria, you can refer the patients as routine. Or if they are reducing the GFR is going down, 25% from the baseline or more than 15 ml per minute per year, then you can refer. And then there are some other referral criteria which I'll just go through. So patients having recurrent kidney stone, if they have unexplained microscopic hematuria, they have difficult to control blood pressure, we'll be very happy to see all of these patients in our clinics. So I'll just quickly finalize this slide. This is an algorithm which we are currently working on and almost finalizing. I'm sorry you won't be able to read this, but this exactly is everything which I have said. And our aim is that we need to develop this, share this algorithm with our colleagues in primary care as well as internal medicine, so that early CKD can be managed effectively in these clinics. Until the patient is ready to see a nephrologist. So the take-home message from my talk is CKD is a silent disease. Screening high-risk patients and early management prevents progression to end-stage kidney disease, which I've tried to show you has significant implications for patients and healthcare system. ACE inhibitors and ARBs, along with SGLT2 inhibitors, slow progression of kidney disease, reduce cardiovascular events, hospitalization, and mortality. And for those with patients with progressive kidney disease, early referral to a nephrologist can help prevent complications and prepare them better for kidney replacement therapy. And the last but not the least, very important, actually probably the most important, is that patient education is essential. Many patients will come to us when we tell them that you need to be monitored. And then the question is, I don't have any pain, I don't have any symptoms, so what's the whole fuss is about? So patient education is very important in managing any chronic disease, let alone chronic kidney disease, for better outcomes. Thank you very much for your attention.
Thank you very much, Dr. Wasim. I think we have 10 minutes for questions. We'll start with you, Dr. Wasim. Do you hear me, Dr. Wasim?
Yeah, I can.
Yeah. There was a question from Ahmed. his question is what would you initiate SGLT2 inhibitor and RAS blockers simultaneously for CKD, assuming euvolemia and hypertension? And the other part of the question is at which creatinine increase you will stop the medication?
So I would personally start one by one, depending on if the patients are, for example, diabetic or hypertensive. So I'll probably start one by one and then get the maximum of one dose and then initiate the second one. Because obviously both of them can cause a jump in creatinine, and I think we don't want that to happen. But that's how I would take it. And the second part was?
Like at which creatinine increase you will stop the medication?
So as I mentioned in my slides, the guideline for the SGLT2 inhibitors is that if it's more than 30%, then we should stop. Up to 30% may be acceptable, but just monitor the kidney function. And more or less the same for RAS blockade as well.
Okay, thank you, doctor. I have a question also for Dr. Dastoor. Dr. Dastoor?
Yes, I can hear you.
Yes, the question is, can SGLT2 inhibitor helps in SIDH? All a question about SGLT2 inhibitors.
Yes, and I think maybe the person who asked this probably knows the answer. It was published recently, and I think in a reputed journal, but there were small case reports a couple of years ago. Yes, they can help in management of SIDH, but I would not consider them as standard of care as yet. I think you should still follow the formula that I gave you, the use of a high osmolar diet, reducing urine osmolarity, and maybe even consider tolvaptans and not SGLT2. But yes, SGLT2 can be considered as one of the new methods to correct SIDH.
Okay, thank you, doctor. Also, there is a question for Dr. Wasim from Mr. Farouk. Is there any drug to halt progression of CKD?
I mean, we just talked about the SGLT2 inhibitors and the RAS blockade. If the patients are normotensive, then still there is some evidence that you can still try to use a small dose of RAS blockade. And as I also mentioned, there is no data coming in that the patients who are even not diabetic, even not proteinuric, we can still try to use, SGLT2 inhibitors.
Okay. Maybe
Sorry, can I, Dr. Abdullah, can I also just add to that?
Go ahead.
What is important is that when you give antihypertensive agents to especially ACE and ARBs to non-hypotensive patients, usually the blood pressure doesn't go down, which is different from giving it to hypertensive patients where the blood pressure declines. And you can also see that with spironolactone, right? We give spironolactone to everybody like vitamins. Their blood pressure usually doesn't go down. But when you give them to patients with high blood pressure, there is a response. So as Dr. Wasim said, you can use these patients even without having hypertension. So they will have renal protective effects. And I'm also seeing there are a lot of questions about finerenone and SGLT2 blockers. It is important to note that now, for the last 20 years, we had only one renoprotective agent, as Dr. Wasim said. There was only RAS inhibition. But now, in the last 3-4 years, we are lucky as nephrologists, we have SGLT2 inhibitors, and we have the new MRAs, such as finerenone. So we should be adding all of these 3 drugs in patients who fit the profile of CKD. Using ACE inhibitors will reduce the progression by around 20% relative to placebo. Using SGLT2 inhibitors, another 15 to 20%, and using finerenone with ACE inhibitors will reduce the risk of progression by another 15%, you know. So these three drugs will become the mainstay of CKD treatment, regardless whether you have hypertension or not.
Thank you, Dr. Dastoor. Dr. Wasim, do you want to add anything before we conclude this meeting?
No, that's actually, thank you, Dr. Dastoor, for explaining it a bit more detail. I think as he said, we were very limited when we had patients who had proteinuria or the blood pressure. We achieved the blood pressure targets, but they still had proteinuria, and we did not know what to do. And now we have stepwise, you can add an SGLT2 inhibitor. If still that doesn't work, you can add finerenone or one of the MRAs, and just have to be careful with the potassium. So if patients are on MRA along with RAS blockade, just make sure that the potassium is controlled. Patients are not becoming hyperkalemic.
Thank you very much, Dr. Wasim. I would like to thank you again, you and Dr. Dastoor, for giving this beautiful lecture at Sunday night. Also, our audience, thank you for joining us. I think we can conclude today's speaks, and we thank you again, Doctor.
Thank you for your invitation. Thank you all.
Thank you very much.